Welcome to our second Medical Mythbusters of the season. For those, I think pretty much most of you have been to a Medical Mythbusters, but just very briefly, we'll be getting two 15 to 18-minute presentations on topics that we will attempt to see whether they are real or myths. Will be voted. There'll be a short 2 or 3 or 4 minute question, answer, comment period after each presentation. Then we'll be voting on whether the question is confirmed, plausible, or busted. Do you have any questions about any of that? Okay. No disclosures. I don't think you guys didn't get paid off for this, did you? You sure? No Russian influence, Ukrainian influence, nothing, Chinese, nobody's paying you? Lucas? Nobody paying you? Okay. All right. So you can see this cartoon here. I don't get all sciencey on me. Just because the royal taster died doesn't mean the food's poisoned. So I thought, usually I'm trying to get some short videos that are related to our topics, but I had a lot of trouble with that this time. So I thought it was appropriate, given our mission of Medical Mythbusters, just to seek the truth in medicine and put dogma on trial, to take a moment to reflect on what's happening in the world of science today. We're seeing attacks on science that threaten to take us back to the dark ages of medieval times, when Galileo was tried for heresy for daring to believe that the earth revolved around the sun. Those were times of superstition and conspiracy theories, when there were no such things as facts. Seems that anti-science has taken root amongst much of the country right now. Climate change deniers, coronavirus deniers, anti-vaxxers, etc. We have a president who believes that whatever he thinks will come true if he says it enough or tweets it enough. We have entered an age of magical thinking, almost as if the age of reason never happened. Science, technology, and innovation, which is what made America great, and this anti-science attitude threatens our democracy, our civilization, and our world like never before. See, here's Galileo, Da Vinci, anatomical dissections, Newton, Darwin, Einstein. This was from the Scopes monkey trial, when science was put on trial. So for hundreds of years, science has been put on trial and threatened, and it seems like we're back to doing that again. Here's amazing alternative medical facts you didn't know. I'm not going to say where all of these comments are from, but you probably know. This is a very short video. Oops. So, science. It's like magic, but it's real. Whatever you do, please vote in this election like your life and the lives of your children and grandchildren, if you have any, depend on it, because it does. So please, vote. All right, so our first presentation will be done by Dr. Nilima Mohan. Both of the presentations today are on primary care topics for internists. And the first topic, Dr. Mohan, will be on should symptomatic adults with subclinical hypothyroidism be treated with levothyroxine.
All right. Good afternoon, everyone. So my name is Neelima Mohan, as you know. I'm a PGY1 internal medicine resident. And so this is my question for all of you today. Should symptomatic adults with subclinical hypothyroidism be treated with levothyroxine? So why did I choose this topic? So I plan to pursue a career in primary care, and this is basic bread and butter. And this is prevalent in up to 20% of older adults. And it's very common to see elderly patients present with very vague symptoms. We've all seen that little old lady come into our clinic and tell us, "Doctor, I feel so tired and weak. Whenever I get up out of bed, I can barely walk around. My muscles feel sore, and I feel so depressed, and I don't know what's happening." And then you get your basic blood work, you check their TSH, their free T4, and you see their TSH is elevated, but their T4 is normal. And I wanted to be able to look at all the evidence and be able to make the best clinical decision for my patients. And interestingly enough, from 2014 onwards, levothyroxine is actually one of the most commonly prescribed drugs here in the U.S. And I think a lot of this has to do with overprescription due to subclinical hypothyroidism. So the general myth, well, if they're symptomatic, they should still be treated with levothyroxine, right? It seems pretty plausible. So let's go ahead and define what is subclinical hypothyroidism. So it's defined as an elevated TSH with a normal free thyroxine level. And the upper limit of TSH will really depend on the specific laboratory, but typically anywhere from 4 to 5. So let's look at some of these prior recommendations. So this was in an abstract published by the European Thyroid Journal in December of 2013. And what they advised is, initially, if you see an elevated TSH with a normal free T4, you should get a repeat in 2 to 3 months, as well as checking for thyroid peroxidase antibodies. And then the rest of the algorithm basically depends on the age of the patient, as well as the specific TSH level. So if the patient is below the age of 70 with a TSH above 10, they recommend that regardless of whether or not they have symptoms, you should still treat these patients. And if the patient is below the age of 70 with a TSH less than 10, it depends on whether they have symptoms. And if they do recommend considering a trial of levothyroxine. And then you would check the TSH 2 months after the initiation of treatment. And once you've achieved the normal TSH level, they also want you to reassess the patient 3 to 4 months later. Now, if there's no improvement in symptoms, they recommend stopping levothyroxine. It's a little bit different for patients that are above the age of 70. So if they are above 70 with a TSH above 10, they only recommend considering a trial if they are symptomatic. And if the patient is above 70 with TSH less than 10, they recommend more of a wait and see strategy. So just observe them and then get a repeat TSH within 6 months. The goal is to keep the TSH within the lower half of the normal reference range, and then you would get a yearly TSH. So let's go over some of the signs and symptoms. So we all know the very common symptoms: fatigue, weight gain, depression, skin and hair changes, muscle stiffness, cold intolerance, constipation, voice changes, and menorrhagia. But some of the less common symptoms that we should be aware of are carpal tunnel syndrome, sleep apnea, infertility, galactorrhea, hyponatremia, delayed reflex relaxation, bradycardia, and mixed edema, which is a type of non-pitting edema classically seen over the anterior aspect of the tibia, but you can see it over the hands, the feet, and the eyelids. So here I have a picture of just the classical pretibial mixed edema. So some of the side effects of levothyroxine. So we all know levothyroxine does have a beta-adrenergic action, and that can cause some of these side effects, including tremors, restlessness, feeling anxious, feeling very irritable, decreased concentration, headaches, and insomnia. So Now coming to the articles that I looked at. So the first one is called Levothyroxine Therapy for Older Adults with Subclinical Hypothyroidism and Hypothyroid Symptoms. So this was published in the Annals of Internal Medicine in May of 2020. And this was a secondary analysis of the TRUST trial, which is the largest clinical trial for subclinical hypothyroidism known to date. And this was conducted from May of 2014 to November of 2016. So this is a randomized double-blind control trial that was conducted in Switzerland, Ireland, the Netherlands, and Scotland. This involved 638 patients above the age of 65 with subclinical hypothyroidism for at least 3 months. And they defined that as a TSH falling between 4.6 and 19.9 with a free normal thyroxine level. And then they were divided into the treatment group and the control group. The treatment group received levothyroxine, a low dose of 25 to 50 micrograms as a starting dose, and the control group received a matching placebo with a mock dose titration. Then the levothyroxine dose was titrated to maintain a TSH falling between 0.4 and 4.59, and then they were followed up for 1 year. So what I really liked about this secondary analysis is that they defined 4 high symptom burden groups, and that was based on 2 quality of life questionnaires and measure of hand grip strength. So the first 2 groups were based off of the thyroid-related quality of life patient-reported outcome, also known as the ThyPro questionnaire. And this had a score between 0 and 100, and they defined a minimal clinically significant difference as a change in 9 or more points. And high symptom burden was either a hypothyroid symptom score more than 30 or a tiredness score more than 40. The third group was from another quality of life questionnaire called EuroQol Group 5 Dimension, also known as EQ5D Self-Report Questionnaire Health Utility Score. This scoring ranged from 0 to 1, and they defined high symptom burden as a score less than 0.75. And the fourth group was a measure of hand grip strength. So they took the best of 3 from the dominant hand, and they defined high symptom burden as less than 20 kg. So these are some of the results. It's definitely a lot of numbers, but if we take a closer look, we see that there's a very similar change in the treatment and control group and hypothyroid symptom score and the tiredness score. And the main thing is that the adjusted group difference is not clinically significant. And ironically, if you look at the third category, EQ5D, there was actually an increase or an improvement in the placebo group, and that is statistically significant. And same goes for hand grip strength. The adjusted group difference is not clinically significant. So what I just said, in all 4 categories, there was no significant difference, and therefore they did not recommend treating these older patients with levothyroxine. So this is the next article that I looked at called Association of Thyroid Hormone Therapy with Quality of Life and Thyroid-Related Symptoms in Patients with Subclinical Hypothyroidism, a Systematic Review and Meta-Analysis. So this was an article that was published in JAMA in October of 2018. And this was a meta-analysis of over 21 randomized clinical trials, which involved over 2,000 patients. And this one, they included non-pregnant adults with subclinical hypothyroidism. So here they didn't really have an age cutoff. And they looked at not only primary outcomes, but also secondary outcomes. The primary outcomes include generalized quality of life and thyroid-related symptoms. And some of the secondary outcomes include depressive symptoms, cognitive function, systolic blood pressure, and BMI. And when we also look at these results, with primary outcomes, there was no significant difference between the treatment and the control group in generalized quality of life and thyroid-related symptoms. And the same goes for all the secondary outcomes, including depressive symptoms, cognitive function, systolic blood pressure, and BMI. There is no significant difference. And therefore, they also recommended not treating adults with subclinical hypothyroidism with levothyroxine. And the last article that I looked at was called Association Between Levothyroxine Treatment and Thyroid-Related Symptoms Among Adults aged 80 years and older with subclinical hypothyroidism. So this was published a year later in JAMA in October 2019. And they just looked at 2 different clinical trials. So the first one they looked at was called Institute for Evidence-Based Medicine in Old Age 80-plus thyroid trial. And then they looked at the subgroup of patients in the TRUST trial that were over the age of 80. So this involved 212 participants in both of the trials above the age of 80 with subclinical hypothyroidism. They were also divided into the treatment levothyroxine group and the placebo control group. And they also looked at 2 domains from the ThyPro questionnaire, the hypothyroid symptom score as well as the tiredness score, and they defined a clinically significant difference of a change in more 9 points. And again, when we look at both of the categories, you see a very similar change from the beginning and the end of the year. And the main thing is when you look at the adjusted between group difference, that is not statistically significant. And the same goes for tiredness score. Ironically, there was actually a similar increase in both groups. And the adjusted between group difference is not statistically significant. And so they also did not recommend treating elderly adults with symptomatic subclinical hypothyroidism with levothyroxine. So in conclusion, just looking at all the evidence that I've presented right now in these 3 articles, there really is no clinical benefit or symptomatic improvement in treating subclinical hypothyroidism in adults. And considering all of these recent clinical trials, the BMJ, which stands for British Medical Journal, they put together a panel of experts to publish a new set of guidelines, and this was published in 2019. And this panel had strongly advised against levothyroxine treatment for adults with subclinical hypothyroidism. However, this does not apply to pregnant women or patients with a very high TSH of over 20. So what they do recommend is just regularly following up these patients, check them back in 3 months, get a repeat thyroid function test, and then to monitor for either the progression or resolution of hypothyroidism. So just a couple of clinical considerations. So again, like I mentioned, this does not apply to pregnant women. Pregnant women with subclinical hypothyroidism actually have an increase for adverse outcomes in the mother and the baby. In regards to younger patients, so in a lot of the trials, their age range was about like 34 to 74. There's not too many patients or much evidence on patients under the age of 30, so these recommendations may not apply to them. We don't have that much research yet. Another thing to consider is a patient with a TSH above 10. So in the TRUST trial, not too many patients had that high of a TSH, and then only 2 trials in the 21 trial meta-analysis actually had patients that had a TSH above 10. So we don't really have the statistical numbers to be able to do an analysis to see if it may potentially be beneficial for these patients. The last thing is antithyroid antibodies. So 3 of the trials in the 21 trial meta-analysis did look at patients that were all positive for thyroid peroxidase antibodies, and they all looked at different outcomes, including depressive symptoms, cognitive function, and BMI. And in all of these categories, they saw that there was no clinical significant difference. But that being said, in general, these patients that have or test positive for thyroid peroxidase antibodies are more likely to progress to overt hypothyroidism, and therefore they should be watched more carefully. But in general, from all the evidence that I presented, I think it's pretty clear that in general, non-pregnant adults do not benefit for treatment with levothyroxine if they have subclinical hypothyroidism, and they should just be followed up. So that's really all I have for you today. Thank you so much. Does anyone have any questions?
Does it make any difference if they have a high TSH and a low free T4?
Can you repeat the question?
Does it make any difference if the patient has a high TSH above 10, say, and they have a low free T4? So they have 2 indices in the lab rather than just 1.
Well, in that case, it would actually be overt hypothyroidism because the definition of subclinical, it's just a biochemical diagnosis where the TSH is elevated, but the T4, the free T4 is normal.
But if they had a low T4 and a high TSH and no symptoms whatsoever, so they're subclinical, it's just laboratory.
I think at that point it's considered overt hypothyroidism. In that case, they would be treated.
Any other questions or comments? Okay, so this is the topic question. The vast majority of symptomatic adults with subclinical hypothyroidism should be treated with levothyroxine. And I put vast majority here because of the caveats about pregnant women mainly and younger women who rarely have this abnormality biochemically anyway. So how many people think this is a true statement that most women that are, or most adults rather, with subclinical hypothyroidism should be treated? How many think it's plausible? How many think it's busted? Oh, it looks pretty unanimous. Looks like you had a pretty strong argument there.
How do we vote when we're not there, Jeff?
You can vote by voice, Tim. What would you like?
I agree.
Is that, what do you say?
I agree.
Okay.